All right, good morning, everybody. Welcome to the Department of Orthopedic Surgery and Sports Medicine Grand Rounds for this month. For those of you who don't know me, my name is Albert G. I'm one of the vice chairs in our department, and I will be introducing our speaker this morning in place of our chairman, Dr. Chansky, who's away this week. Thanks everybody for being here this morning, and a special thank you to Dr. Paul Pottinger, who's our speaker this morning. Just as a housekeeping reminder, I don't know that we posted it here, but if anybody needs, just remember to send your CME text to get CME credit. If you have any issues with that, send me an email or a text message, and I'll send you the link. I think we all have the number saved on our phone now. Okay, so now to our speaker. I think many of you have had the pleasure of working with Dr. Paul Pottinger. I know I have. He's a professor in the Department of Medicine here at the University of Washington in the Division of Allergy and Infectious Diseases. He's an infectious disease specialist, and that's been the role in which I've interfaced with him the most. He's the head of the general ID section. He's also the co-director of the Antimicrobial Stewardship program at our institution and also the chief of the Division of Tropical Medicine. So anything ID, I have Dr. Pottinger on speed dial, and he's always incredibly quick to respond and always happy and willing to help us with infection issues, which obviously in orthopedics we do face a considerable amount of those challenges in our patients. I think many of you know also, but for those that don't, Dr. Pottinger, outside of work, is a very avid and accomplished mountaineer. I think Paul, have you summited all the highest peaks on each of the seven continents now, or
Yeah, yeah,
just
believe it or
okay,
not,
you have.
I
Wow,
didn't have
awesome.
enough to do. I figured I'd
Yeah.
fill my free time with that.
Yeah, he's hit all the peaks, including Mount Everest, which he summited in 2016. If you guys are interested in this story, I think it's posted online. It's a pretty easy Google search. Just look up Dr. Pottinger and Mount Everest, and there's a cool story that the UW has put together online and describes the incredible adventure that was, because obviously the year before when he first tried to summit, that was the year that they had that very bad earthquake up in that region, which caused some tragic accidents and such, and which fortunately Dr. Pottinger was not involved in. But he is and continues to be an incredible partner to our department, and we are very honored and happy to have him for our grand rounds this morning. He'll be speaking on infectious diseases updates for orthopedics, partnerships, and opportunities. Paul, thanks again for being here.
Yeah, it's so kind of you. Yeah, I was channeling you and Seth and Paul in 2015. That's all we had at base camp was orthopedic injuries, knees blown up and stuff like that. So
Yeah, I
they
can
were
believe
stuck
that.
with me, sad to say. Well, I appreciate this invitation a lot, and it's good to see old friends and make new friends too. Um, yeah, let's get rolling here. I was asked to give my disclosures for this talk, and I have a lot of conflicting interests. I'm basically a full-time clinician at Montlake. I also do a lot of medical education with our ID fellows. I'm conflicted about how much time I get to spend with them. When I'm doing that, I feel like I should be up in the mountains doing that. And when I'm doing that, I feel conflicted because I should be spending time with my happy family. They do grow up to be happy adults. Yeah, no financial conflicts of interest. It's ID. We don't have any money. That's the problem. Maybe that's the point. So the objectives that I had for this were to talk about prosthetic joint infection prevention, because it's either Paul or Seth told me some years ago, this is the rate limiting step in orthopedics. It's not technical stuff. It's not the titanium. I mean, that's a problem. Your carpentry and artisan work, it's the infections. That's what holds you back. And so how do we prevent this? However, I've also carved out some time for pearls on how to make a diagnosis in partnership with ID, and of course, some pearls for treatment. And I do have time for Q&A at the end too, and I hope we can do that. When it comes to PJI, it's a huge problem, right? You are putting in so many prosthetic joints, and we project this could be up to 4 million people. I think there's, 300 million of us in the country. So more than 1% of Americans getting a prosthesis per year by the year 2030. We'll see if that happens. Ozempic may change this. But the concept here is that you have a lot of indications for doing this. And, here at UW Medicine, we just assume that, of course, there's elbows and shoulders. These are exotic. These are rare. And although we're leaders in this area, more and more places are doing other joints beyond hips and knees. And I think it's the obesity rate that drives it. That's that little animation you can see. It's the embiggening of America. And we have come to assume that Americans are so heavy. This has happened in a lifetime. Within the last 20 to 25 years, people have put on their BMI like crazy. And that's driving this hunger and appetite for prosthetic hips and knees. And it's a problem, right? For every prosthesis, that individual person and that joint, some people have more than one joint, that every single joint has roughly a 1% chance of getting infected. That's usually in the first 2 years, but it could be at any time. Knees are worse because the biomechanics are impossible. I don't know how Albert does this. They're just so damn difficult, and the stress and strain that's there. And every single one of these is pain for the surgeon. And you will, for those of our trainees, you may have some residents, fellows here, you own every one of these. And now this is my profession. I'm happy to do it with you. If I never saw another prosthetic joint infection, I would happily retire my practice. I'd be thrilled. My wife would be thrilled. I hate these infections. They're just so problematic. So there's a lot of focus, and appropriately so, on preventing them by giving IV antibiotics. That's our gold standard. And as you know, it's cefazolin, right? That's a first generation cephalosporin. That's the IV flavor of Keflex or cephalexin, which is our PO version. We prefer this because it gets MSSA, it gets Cutibacterium, which is something our shoulder and elbow team really struggles with within prosthetic shoulder infections. It goes after a lot of E. coli. We don't usually treat E. coli with Keflex, but sometimes you can, and same with cefazolin. And even some of the coag-negative staph or staph epi is treated this way. So cefazolin, it beats out others when compared with to my knowledge, any other comparator antibiotic is inferior. Certainly with respect to vancomycin alone, for example. That's been true in hips and knees. We now have data this is true in shoulders as well. So cefazolin's your drug, and your dose depends on the patient's size. 2 grams for most, an extra gram to 3, please, if your patient is 120 keys or greater, just actual body weight, no adjustments, nothing fancy. Put them on the scale, 120 or greater, give them 3 grams. We will redose during the case. Most places on planet Earth will do that every 4 hours. Here we do it every 3 to 4. We're worried about blood loss. We're worried about third spacing and all that stuff. So it's very difficult to harm your patient with cefazolin. I probably have done that at some point in my career, but it's safe, it's clean, and it's effective. And I would say it's also no good for MRSA. So if your patient truly has a history of MRSA colonization or infection at any time in their life, we would add vancomycin. We only rely on vancomycin alone if we just cannot give cefazolin. That's rare, but occasionally it comes up. And this is my little pearl. Prohibitive cephalosporin allergies are super duper rare. Penicillin allergy labels are very, very common. How do we figure this out? It's 10% of Americans will tell you they're allergic to penicillin. I won't ask for a show of hands here in this community. Many of us, I'm one of them, actually has one of these labels in their chart. In UW Medicine, it's not 10% of our patients, it's 20%. 1 in 5 UW patients will have this label on their EPIC chart. And you're going to look at them to give them a prosthetic joint. How do you figure this out? What are you going to do? As you know, the great majority of these are bogus. It's either historical, or it was nausea, it was not an allergy, they just barfed a little bit, or they had yeast infection or something like this. And we know that anytime we go to something else, there's a 50% increase at risk for surgical site infection. And so it just makes me scream and curse, and it blows my lid that we're giving, in 90% of these cases, we're giving the wrong drug based on the wrong information. So we have made a way forward for you. I could talk about this all day, but I won't. This is all I'm going to show you. This is my Shaka sign. This is the guideline that we have for you as you assess your patient preoperatively to decide what their prophylaxis will be. And I think our advanced practice providers know about this resource very well. I'll show you the link in just a moment. But we built it like a traffic sign, right? Red, yellow, green. There are some labels that get our attention, and we will never give a beta-lactam again. Stevens-Johnson, right? One of these horrible dress reactions, a drug reaction with eosinophilia. Those are deadly, and we don't play with that. But almost everybody else, including anaphylaxis, Yes, they can get cefazolin. If they have a history of penicillin anaphylaxis or hives, everybody in Seattle has hives. It's a Seattle thing. That's when they were children. They got amoxicillin from the pediatrician. They actually had EBV. And there's this funny thing when you get acute EBV and amoxicillin, you get a rash. That is no big deal. And even if it's proven anaphylaxis to penicillin, they can still get cefazolin. This is totally different from the way I was taught in medical school and what I have taught myself in medical school. The new data shows that this is safe. So please refer to this. And by the way, we've also built a cephalosporin allergy label tool because a lot of our patients will have a ceph allergy in their chart, and that we also have this resource for you. It's called Pallergy. This is the team. We've put this together for you. It includes not only pharmacists, ID doctors, but allergists, people who know what they're talking about, and even the mighty Al Marati, king of flow in our operating rooms at UW Medical Center. He endorses this as well. Cefazolin, not just better for your patient, better for flow in the OR, because the anesthesiologist can slam it in over a period of minutes. With vancomycin, it's usually 90 minutes to get in, so it's a real issue. If you want to find this, I hope that all of you have this resource on speed dial, as Albert said. This lives on all the workstations, but it also can go as an app on your phone. Just type in UW Occam. Occam, as you know, is a suite of little applets. The one that we have built is called the Antibiotic Reference Kit. And if you open that up, yeah, we have a penicillin allergy resource. You just click on that and it'll walk you through this process. We have built it so that a doctor or advanced practice provider can click that button, sit with their patient, and within 2 minutes, they'll be done. And it gives you a little in text. It says exactly what you can and can't do. So I would love to have you use this if you're not already, and would really welcome your feedback on this, and including on the little applet on your phone. The reason I like it on your phone is that when I make a change, it'll push to you. You're always up to date that way. And it's based on local guidelines and what we are seeing here in our own patients. Anyway, regardless what you choose, I think you've all seen this spline curve. The closer you give and complete the infusion to the time of incision, the lower your risk of infection. And that's what's shown here. The vertical axis is risk of surgical site infection, time on the horizontal axis. 0 is the incision. You really want that to be done within 30 minutes before you cut. That would be ideal. And we want to get as close to that as we possibly can. So when we think about antibiotic timing, that's what usually comes to mind. I want to get the timing right with incision. And that's correct. But one of the other controversies or conundrums for all of us is, okay, that's how we start. How the hell do you stop? How long to give prophylaxis? It remains unsettled, and I think it's a little nuanced. I'm going to walk you through this. You know, the World Health Organization, CDC, the Surgical Infection Society are all clear. There should be no postoperative antibiotics, period. Once the patient is sewn shut, you're done. Their fate is sealed. Well, AAOS and the MSIS, Musculoskeletal Infection Society, they really hew to this idea that the absence of evidence is not the evidence of absence, and that we should stop within 24 hours. That's how a lot of these trials were done, that within a day, so that patients are permitted to receive another dose or 2 of cefazolin after the case is done. In 2018, Paul Manner was kind enough to invite me to come to Philadelphia for the Orthopedic Research Society a consensus meeting. And at that time, that's what we came to. It's my recollection that we would stop within 24 hours of closure. It's sort of auspicious. That meeting's happening today in Istanbul. And so we'll see what comes out of that based on this more recent paper that post-dates that 2018 meeting. This is the paper that's gotten a lot of attention, and properly so. It's a pre and post design run by our friends, colleagues in Indianapolis. And what they did was they had their usual approach up until 2015, where people got no post-op antibiotics. And then they just changed that everybody who was at high risk of getting a surgical site infection, because they were seeing a lot. I'll show you. It's crazy what their rates were. They decided to give a week of antibiotics PO after they closed. And then they just compared pre and post. What did they give? It could be a cephalosporin, could have been clindamycin or Bactrim. It was sort of dealer's choice, but most of them would get a ceph. Then they followed them for the first 3 months to see who got a surgical site infection. The risk factors that they thoughtfully and correctly put together were listed here. And I think these are the risk factors that just put fear and loathing in the heart of every prosthetic joint surgeon, because we know that these are the issues that tend to drive surgical site infections. So first of all, it's a pre and post design. It was not randomized. There was no placebo-controlled trial. It wasn't even step wedge, just flip a switch. And here's where we go. And except for a couple of things, some diabetes and some nasal colonization a little different. Otherwise, I think these were really well-matched groups as it happens because they had a large number. So that's encouraging. Gadzooks, our friend, and I don't know these guys. And I say, guys, I think it's mostly men operating in Indianapolis. Man, they had a lot of infections before they did this. And if I was looking at total hip, total knee arthroplasty infection rates looking like this, I'd do anything to make it better. I mean, I dance for the rain gods or whatever. This is bad news. And so it's true that in their post situation where they did extend antibiotics, as you can see, the column on the left, they had a substantial reduction, going from 10 infections out of 468 down to 2, for example, for people with just one risk factor in the knee. So they really had to do something, and going to this, I think, was totally reasonable thing for them to try. And I would just call out that in particular, it really was in that Indianapolis cohort, it was obesity. And in fact, they had a lot of people with a BMI of 40 or greater. And you can see that they had, a lot of these cases. And indeed, they were reduced with respect to getting postoperative antibiotics. And so I just wanted to call that out because we have patients of that size here too in Washington. It does indeed happen. But I would say that our experience, at least with respect to the Northwest campus, is dramatically less. Our baseline is, really at or below what we would expect with any national comparator. What we do, and this is thanks to Seth Cohen, who directs our infection prevention program at both campuses, Montlake and Northwest. These are publicly reportable data. Every surgeon participates whether they want to or not. It's called the standardized infection ratio, and based on risk factors of the patient, we decide whether we do or don't think we're getting an unexpected infection. The concept infections, we like to call them zero or never events. They happen. Even with the best of techniques, they're going to happen. CDC honors and respects that and says, okay, how do you compare with the rest of the country? And at Northwest, we compare favorably. We want this number to be less than 1. And SIR of 1 means we're at par with everybody else, and we're consistently less because of the virtuosity and excellence of what you guys do up in Northwest. So our surgical site infection rates are dramatically lower up at Northwest than they are compared to our friends in Indianapolis. The data I'm showing you are going back to 2018. I don't have more recent data, but it's not my understanding that things have gotten worse. If anything, that they're looking slightly improved. I'm happy to talk about that too. So for me, this paper, the bottom line is it's very intriguing. They had a super high risk cohort and a lot of what I would call extreme obesity. And they weren't looking for C. diff and other potential harms, resistance with these prolonged courses of antibiotics. I think if we're going to do this, we should choose our patients based on those same risk factors, and we should stick with that. A week of oral antibiotics in those high-risk people is totally rational. We'll see what comes from Istanbul. I suspect this will be endorsed or reflected in the latest ICM. I think Jason Shu and some of our colleagues are there. We'll see what they bring home. We're looking forward to seeing what that happens. Again, if you're going to do post-op antibiotics, should be PO, should be high-risk cohort, and should be a week long. And I just want to emphasize that I'm a germ doctor. I think about antibiotics for a living. It is a small part, important part, but it's only one part of what we can do to prevent these infections. And in particular, we have trainees here today who are considering going into arthroplasty. Thank you for doing that, doing the prosthetic joint. That's great. Talk with your faculty. Talk with the attendings that you work with when you scrub in, and ask them about their selection of these cases. I'm not talking about the trauma world. That's different. You don't choose. But with an elective case for a prosthetic joint, just ask your faculty what they do as they think about how to choose those patients. We can't just cherry pick the healthiest people for a bunch of reasons. If they were healthy, they wouldn't need a joint. But the key is that you're going to identify these risk factors, and please don't just identify them. Your faculty are working hard to reduce them. I mean, if you see that someone's high risk, try to fix it before you operate. This is the idea, and I'm just super fascinated by the current Ozempic rush. These GLP-1 agonists, they've gotten a bad name as something that people in Hollywood do for vanity. That's not how this works. I mean, it does reduce obesity. I just saw a patient in the ER last night proudly told me he had lost more than 200 pounds on something called Manjaro. It's one of these drugs, tirzepatide. 200 pounds just by taking a shot once a week. So I'm hoping this is going to radically not only reduce our need for hips and knees, but also when people do ultimately need them, that their risk of infection is less because they weigh less. If patients are depressed, that should be treated. That's inexcusable. We should always treat these people. If they're seeing a rheumatologist, how low can you go on their fill in the blank, their biologic, their methotrexate, whatever it may be, prednisone, and on and on and on. And I think, people who are living with addiction, that should be addressed before they go into surgery. You're going to set them up to fail if you send them out on oral oxy or whatever it's going to be. So it's hard, is my point. And you probably chose a career in orthopedics because you really enjoy that experience in the operating room. It's key. In my opinion, it's a small part of what you do. I think that pre and post-op care is a huge piece of orthopedics. And all of these are examples of that in partnership with medicine, et cetera. I'll call out the bottom piece too, because this gets called out a lot. This is one of Seth Leopold's favorite causes, and I think he's right to talk about it. What do we do with Staph aureus? Because this is the big beast, right? Staph aureus is going to be your leading carnivore in most prosthetic joint infections. It's not true for the shoulder. There it's something called Cutibacterium acnes, as Rick Mattson and all of his amazing colleagues know so well. But for most prosthetic joint infections, it's about the staph. And what we know is that if we, based on this paper, it's showing its age, but it's still a good one. We know that if we get rid of staph from that patient, that they're much less likely to have a Staph aureus infection of their prosthetic joint. Reoperative decolonization works if we can do it. And that's what you see here. Looking at total joint arthroplasties group in New York, at least led by New York. And this is what they found. It was a pre-post design, again, not step wedge, not randomized, but they did cut their rates down substantially, as you can see. And so that's exciting for us. It makes sense. If the staph's not on their body, it's not likely to hop in as an immaculate conception of staph and get it off the patient, and it's not going to get in the wound. Well, that's fine, but it does come with this issue. In fact, a whole family of problems. So we know that decolonization can reduce your risk of surgical site infections, but it can be hard to do. What these patients have to do is stick mupirocin or Bactroban in their nose twice a day. They got to bathe with chlorhexidine daily for the week before they come in for the case. Where do we even look for the staph? Most people check the nose. I think if you're doing a hip, it makes perfect sense to look in the inguinal fold. If you're doing a knee, does that mean you look behind the knee as well? That's not settled, although it's not wrong. We just don't have good data on this. Mupirocin, in the studies where this has been done, you won't see this report in EPIC. Nobody looks for this. A lot of resistance, in vitro resistance. Like 40% of these Staph aureus isolates are actually mupirocin or Bactroban resistant. And you won't know that before you stick it up somebody's nose. Chlorhexidine hypersensitivity, you've seen this, right? People come in with dry skin or a rash. You don't want to slice through irritated skin. This is a problem for the surgeon. And we know, based on some good studies, that people don't do this. They just don't follow the instructions correctly. And if you do, and you do a seek and destroy, I think this is Leopold's idea. He wouldn't operate until he knew that patients were cleared. You can take up to 11 attempts of monthly cycles, up to a year, to get rid of this Staph aureus. Some people are just hard to clear. What we've pivoted to instead in our practice at Harborview, at Montlake, and at Northwest is intranasal povidone iodine. It's not just the PI you get in the bottle. This is a gel. It's an FDA-approved metered dose that the nurses should apply in pre-op holding, swab in each nostril. What that's going to do, what it's got the FDA indication for this, because it's proven to dramatically suppress Staph aureus. Whether the patient has staph in the nose or not, and whether it's MRSA or not, that Staph aureus risk is reduced for any surgical procedure. And our friends who do the thoracotomies, sternotomies, they love this because their open heart surgery is just a few centimeters away from the nose. It helps in that context as well. So too with orthopedic surgery. It's not decolonization. That metered dose goes away. The Staph aureus will regrow eventually, but while the patient is open and in that golden first day of surgery, post-op day 0 to 1, the staph is suppressed. So that's what we're doing. You're seeing that in your patients if they roll into the OR with these red strills. That's what's going on with that. Regardless, if your patient does have a history of a problem with Staph aureus, please just add Vanco on top of cefazolin. That's our earnest request for you. A couple other fine points. In the old days, we used to always check a urine before we would do a joint arthroplasty. We, out of the best of intentions, the thought is, oh my God, if this patient's got bacteria in the urine, we don't want it to get to their fresh joint. It's rational, but it just doesn't happen. It's just extraordinarily, extraordinarily rare. So for something called ABU, asymptomatic bacteriuria, this risk is super duper low. And in fact, the risk of giving them fluoroquinolone, for example, actually exceeds the potential benefit in this context. So our friends in urology, they need to know. They're slicing through the urethra. That must be a sterile area. But if you're doing a hip and you end up in the urethra, something has gone very sideways. So for your context, this should not be a hassle for you. I'm grateful to all of you for getting that Foley catheter out. If they need one at all, please get it out of them within the first day. But for symptomatic UTI, that's different. If a patient rolls in for their knee and they say, God, I got to rush to the bathroom when I got to pee, the case is canceled, just as it would be if they had an infected ulcer on their ankle. You wouldn't put a knee in a patient like that either. So that's the concept. For symptomatic UTI, stop, go see primary care, come see me in my clinic, we'll fix them up, reschedule. But when it comes to asymptomatic bacteriuria, don't ask, don't tell. And this is not just me personally, my little stump. This is true for IDSA and the ORS from our last consensus agrees. This is something we should not do. So that makes your pre-op workflow a little bit easier and important for your boards. Likewise, the same is generally true for oropharyngeal considerations. PJI almost never originates from the mouth. And so my friend Tom Hahn has gone through the literature and put this slide together. I like this a lot. And you can see certain risk factors on the left for bacteremia, bacteria in the blood, related to different oral risk factors. And if we use, and so you can look at that list and decide which you think is the riskiest or the one of greatest concern. But if we use a tooth extraction as a relative risk of one, it's daily life that is by far the riskiest thing you can do, and not a dental exam. A dental exam is, or not nearly as risky as brushing our teeth, which hopefully we all do a couple of times a day at home. The point is that bacteremia happens. It comes from our mouth, and going to the dentist is in most cases, actually a relatively low risk for that to become an issue. So the current guidelines emphasize the daily activities incur the highest risk, not dental exams. So we used to always give patients with any prosthesis, a dose of antibiotics when they go to the dentist. This is the way we've always practiced. It's only within the last few years that this has changed. And I want to emphasize that for our trainees, if you sit for your boards, this is now the standard of care. I would emphasize oral health is really good. This is important, but the risk of getting in trouble with prosthetic joint infection from your mouth, so small. I've seen it. It is a real thing. I've been doing this 25 years. So it does occasionally happen, but it's super rare. And this is what we're doing not only in prosthetic joint prevention, but also for endocarditis prevention. These indications have narrowed. And this comes from the American Dental Association in general. Antibiotics not recommended for dental procedures to prevent PJI in general. But I think our residents should know that there are exceptions. I would recommend perioperative, periodontal prophylaxis with amoxicillin, 2 grams, for example, in someone with HIV that's not controlled, a patient who has to have dental care and they're receiving chemotherapy for cancer. They're on a biologic, they're on a DMARD, they're a transplant recipient. These people should get antibiotics to prevent prosthetic joint infection. So these exceptions to the rule are important to keep in mind. I'm going to pivot from prevention over to diagnosis because this happens, and that's our mantra at the top there, that quote, "We are ID, we come in peace." And I want to emphasize that because the traditional scenario is as a patient in the ED, there's a red hot leg, it's usually cellulitis, and there's concern that the joint might be septic. And for whatever reason, we tend to get to see them sooner. I don't know why that is. So I've seen that a lot where our ID fellows will say, "Ooh, I think this could be a septic joint, call ortho," to have them assessed. And so we are the genesis of a lot of your painful consults at all hours. I'm sorry about that. We do come in peace. And like you, we're just worried about the sanctity of that collagen surface and the integrity of the joint. We're trying to preserve that. So if we do ask you to come and see the patient, thank you. We need your expertise. We're just not qualified to do a good knee exam. We just aren't trained in it. We could do better, but we could never be as good as you are. That's what I would say. And if there is a difference of opinion after you see the patient about whether the joint should be tapped, ID says, "Please tap the joint." You'll see them say, "Look, I don't think they need a tap." No problem. This comes up. Be so helpful if we talk by telephone. In person's best. It's so hard to do in-person meetings anymore. It's like difficult, but if you just shoot us a quick epic chat, we'll call a quick cell phone call, even 1 or 2 minutes, helps to clarify things and make sure that the charts are civil and clear and moves things forward with that patient's care. There may be reasons that we're extra worried about this person, they're neutropenic, there's something about their immune system that you wouldn't know or that we haven't articulated. That's what we would like to do with you by telephone. And you might say no dice, and that's okay. That is okay. If there's ever a concern during a case, you're doing a revision or a primary and you get in trouble, what is going on here in the joint space, call us or epic us right away. We can always discuss with you right on the spot, and we'll talk about what kind of testing that we would propose. If in doubt, give us a call, and we'll chat about it. What we're going to ask you to do is something more than blood cultures. I think you know this. Blood cultures are fine to send. They're just not good enough, right? That's why we got it. If there's any concern for septic joint, we got to get into that space. So if you do send blood cultures, please send 2 of them. That's very important. Otherwise, you're going to have coag-negative staph in 1 of 1, and we don't know what to do with that. So we do appreciate your sending 2 at a time. Once in a while, we'll come up with an oddball serology. Send a Brucella serology or something like this. That's fine. We play these games. It will never change what you do with that patient in time. These take time to come back. They're slow as hell. And your clinical orthopedic savvy with this patient is what we're really looking for in real time. Likewise, with other markers of infection, yeah, if you send a CBC, please add a diff. That's like our religion. We want to see the neutrophil count. This is just the way we are. These can suggest infection, but they just don't have good enough negative predictive value. If there's concern for osteo or for prosthetic joint infection or native joint, we really need to get tissue. Tissue is the issue because we need the bug in a jar, in a dish, so we can torture it with antibiotics and tell you exactly how to kill it. So in ID, we love pus. This is our whole thing. And meat, gristle. I remember once walking down to the lab with an amputated foot. The lab, I'm still famous for that because the lab was not happy about me bringing a foot for them to culture in the lab. But we really do want to get the sentinel tissue down to the lab. The way to do this is to take whatever is looking suspicious to you that you're removing from the body and just put it in an empty, sterile plastic cup. No saline, no fixative, nothing. Meat or fluid in a cup. That's the ideal specimen for the lab for a bunch of reasons. The gram stain gives you a sense right away for the burden of organisms. We can grow things more quickly, and we can easily do molecular testing as well. If you're tapping a joint or you're slicing into a compartment, whatever gushes out, that first gush, that's what we're looking for. It doesn't take a lot to put into that cup. Even a few cc's is plenty. You can send us a whole cup of pus, that's fine too. But even a few cc's is good enough. If you're hogging out, a membrane, a humoral membrane or something like this, these fruit leathers, piece of gristle, stick it in a cup and send it to us. That's fine. The lab can totally work with that. A dry tap in a joint, you can do some lavage. As long as it's sterile saline, you're in the OR, it should be fine. And 50 cc's to wash, barbotage, whatever you want to call it, send that off. That's okay, although not as great as if it were fresh. This came up in our practice just yesterday as well. The challenge, and I'm happy to talk with you more about this because I want to get your opinion on how to do it consistently. When our micro lab sees something called a wound, they treat it as garbage. They think it's an open wound like a diabetic foot or something, and they don't work those up as aggressively. If this is an incision into, that you've prepped the skin, you've gone into that joint, it's not a wound, it's a tendon, it's a knee. It should be labeled as the anatomic site as a tissue or a fluid. So the specimen type would be tissue or fluid, not wound. And then the source would be fill in the blank, knee, bone, whatever you want to call it. I think our really wonderful circulating nurses and scrub nurses, they, especially the circulators, they call everything wounds. There's a huge difference between a community-acquired wound and a surgical wound that you just made. So I really hate the W word. I think we should get away from this. That way we get you higher quality information for this precious specimen that you've just spent all this time harvesting for us. And don't say the S word, no swabs if at all possible. So this is my little soapbox on the swabs. We hate them. Swabs are a problem. They're fast, they're easy, they're just not as good. It's harder to do a gram stain off of that. We don't know the burden of the organism. It may not be possible to run a PCR off of a swab. Harder to grow things from this. Swabs, they're definitely better than nothing. I will not be cross if you send us a swab because there was nothing else there to remove and send in a cup. Then that's what the swab is for. This is your backup plan. But in general, a big bowl of bat. These are bacterial. So when you send them to the lab, what do you test? And what I'm looking for is a gram stain, ideally a stat gram stain. So you get that information before you've closed, and a culture. Prosthetic joint, native joint, osteomyelitis, it's bacteria. And here's an example. This is a patient I saw with Seth Leopold years ago. This guy at that time was in his 70s. He's now in his 90s. I just saw him last week, still going. He had a prosthetic knee, and he was shredding the gnar up at Stevens Pass, got a blood blister on his foot, and then his knee blew up. And sure enough, so it was my patient. Seth saved him, so I went into the OR, and it remains to this day the single most floridly positive gram stain I've ever seen. And that's the picture you see there. This is group A strep from a blood blister on his foot that got into the prosthesis. That little picture on the far right, as you remember from med school, and you hold it up to the light, that's called beta hemolysis. I mean, we knew exactly what this was. This guy needed penicillin. In fact, he remains on penicillin suppression for reasons we can talk about a little later. But it's bacteria. So that's what I'd ask you to send in all of these cases. And it's true, if the patient is pre-treated, that may reduce your risk. But if there's a septic joint and a septic patient, give them antibiotics. That will save their life. And we can deal with that later. I can always handle this issue subsequently in the lab with molecular testing. So for an acutely inflamed patient who's looking sick, low blood pressure, et cetera, they need antibiotics, and we'll deal with this on the back end. And that's just totally fine. And so cell count is important. Crystals are important. Once in a while, we're fooled. It's gout. It's pseudo gout. We appreciate you sending this for crystal analysis as well. And I've just been punked so many times, positive that this is an infection, and it's not. It's actually just gout, or vice versa. So these are always sent together on a joint fluid. And so thank you for doing that. If your patient is stable with a hip or a knee, smoldering symptoms, but they're non-toxic, they might even be outpatient in clinic, then we really do, yes, thank and appreciate you tapping that joint before they receive antibiotics. That can really improve our yield in that context. But again, if the patient is septic, of course, we would always give antibiotics first. We will not be cross with you. We will thank you for saving that patient's bacon. If you're worried the cultures won't grow, you're going to consider sending PCR. As I think you probably know, UW is the world's leader in molecular diagnostics. Just by coincidence, we're here. Sometimes people don't realize that. So we have hot and cold running molecular all day long. PCR, they can do it, but it's expensive. It's about $1,000 per run, and it's usually not necessary. For patients who are pre-treated with antibiotics or very fastidious organisms, molecular can be very helpful. That's true, but it's uncommon for there to be just PCR positive, culture negative, even in our pre-treated patients. If you think about it, if my antibiotics could fix a septic joint, we wouldn't have to drain the thing. So usually these are privileged spaces. The antibiotics don't get in well, and the bugs are still thriving, even when they're getting vancomycin, et cetera. So here's my humble request. Please do not routinely send PCR. If you send a fluid or a tissue, the lab's going to hold on to that for a week. They chuck the swabs after a couple of days, and I'm working with them to try to improve that. But if you sent them fluid or tissue, that stays in the fridge for a week. If nothing grows within the first couple of days, then we add a PCR and we see what shows up. This can just save about $1,000 per test. So if you're considering PCR, you may be exactly right. Just send us a text, give us a call. We'll talk about it. We see a lot of AFB and fungal cultures coming out of the operating room as well. You may be worried that it's not bacterial. So this can happen. I've seen this. It is rare as hen's teeth. These are super duper uncommon cases. It's seriously rare. And indeed, when we're thinking about these, those are usually going to be cases that we in ID have sent to you in ortho, begging you to tap them because of a long-standing smoldering process, tuberculosis in the spine, or whatever the case may be. So for that reason, yeah, please, no need. In fact, please do not send fungal or AFB cultures unless you've talked to us ahead of time. Or again, if there's something weird in the case, call us. We'll talk about it. But AFB and fungal culture should not usually be part of the routine testing. It's bacteria. That's what we're looking for. When it comes to treatment, and I'm going to wrap up here soon so we can have some time for interactivity this early in the morning. I think that's good. But holy smokes, it's hard. And I think we all talk about biofilms. I'm just showing you here up close what these biofilms can look like. And this is a K-wire or a pin or something that's been placed, infected. And this is a huge problem. I mean, these bugs move from their planktonic, active, reproductive state into this zombie form. We call it sessile form. They're zombies. They're like the way you feel after Thanksgiving. You're fat and happy watching the game on the sofa. That's what they're doing. They're not reproducing. They're not putting up new cell walls. They're not expressing their penicillin binding proteins. They're not nearly as susceptible to antibiotics. They're not expressing those antibiotic targets. And they've also covered themselves in this glycocalyx slime, like a raincoat. So this is the issue, right? As you know so well, biofilms are terrible. And it's not clear to me that any antibiotic will actually work in this case. We've all been there. I do have cases where the patient simply could not undergo surgery for a variety of cardiovascular reasons, risk reduction, all that stuff. I think I have cured people in this context with antibiotics, but it's rare. This is all about source control, right? The case of Cutibacterium is a good example. We struggle with this mightily on the shoulder and elbow service. The leading organism that we see at the time of revision for pain or stiffness from an index case. And as you can see, this is a Cutibacterium that gives us acne as teenagers. It's on our face, especially male patients, especially on the sternum and the shoulder. And gadzooks, it is very, very drug susceptible. If you look at this, you just say the word penicillin in the lab, it'll die. But in a prosthetic joint, I can pickle these patients' shoulders, their bloodstream with antibiotics for years. It will still persist and come back unless we've gone in and hogged it out and gotten source control. It's not about resistance. It's about source control. So what I try to tell our ID fellows is that the context is everything. I mean, we could be called, this is a case from our VA, but it could happen at any of our hospitals. And we'll be asked what antibiotics are good for this patient. And the answer is amputation. I mean, this is a surgical case. It's not a medical case. And no antibiotics are required. If there's a appreciable ascending cellulitis, we can deal with that, but we'll never fix this with antibiotics. And you know that very well. We know that very well. The patients don't get it. And so together we can stand shoulder to shoulder with you and set expectations. We do haggle with patients. Here's a person living with suboptimally controlled HIV and diabetes, wearing a shoe that was too tight. They got this ulcer. And this was substantial osteo at that first met head. And they didn't want to have surgery. They wanted to try to save the foot. And we did. We gave antibiotics and things looked improved. Ultimately, this patient, I think, ended up with a ray. But the point is, whether it's the diabetic foot or other contexts of prosthetic joints, it's about that context and setting expectations with the patient that are realistic. In prosthetic joints, that's the same story. So here's a patient with rheumatoid arthritis who'd had an elbow surgery. As you can imagine, numerous elbow surgeries, and then revisions. And somehow, unfortunately, methicillin-sensitive Staph aureus got into this joint. And, ID became involved, and the fellow said, we're going to get source control, pull out the elbow, and we'll give you antibiotics. We'll get you a new elbow. You'll be okay. I mean, that is not the right way to do it. We should always talk with the surgeon first. The concept of putting a new elbow into a joint like this, I mean, it's not a small deal. And setting expectations for this person about what kind of functionality they might have after the resection. Would they even be a candidate for any kind of reimplantation? And how much of a cerclage wire burden are they going to have for their periprosthetic fracture, which is absolutely going to happen when we pull that stem. So our aspiration, and what I really tell our fellows, is talk to the surgeon first. If we at all have time before we talk to the patient about what things are going to look like, we need to come to you and understand the realities of what can and can't happen. And if that doesn't happen, please don't get cross with the fellows. You can have that. Remember, we're a teaching hospital. We're all learning. I know I am. And if they say the wrong thing, be kind to them, and let's try to elevate that process. We should talk to the surgeon first, because as you know, the usual process, I mean, this is in textbooks. I won't go into the details. 2-stage arthroplasty resection. This works for hardware-associated chronic osteomyelitis in the prosthetic joint context. And we pull the hardware. We thank you for reaming and ronduring and taking a brush and doing whatever you have to get all the goo and biofilm out of there. We give them the poisonous bug juice. We handle that. You don't have to deal with any of that. Then we take a holiday, and then we send them back to you. And depending on how things look in the operating room and what testing shows, they may be a candidate to reimplant, or they might need another antibiotic-laden spacer and come back and just start over again. This is our gold standard. Everyone knows this. But even as our best, most likely to succeed situation, number one, that may be very morbid for the patient. Number two, it doesn't always work. Even if we follow the rules, there are failures. So that's with the 2-stage. What about DARE, where we debride, give antibiotics, and implant retention? We love doing this. This is great for us, for you, and for the patient. As you know, what we're looking for in general when we consider DARE, if we had the choice, would be an early implant or symptom onset that's been very recent. The implant must be fixed, obviously. There should be no chronic sinus tract, and you should be able to go in, swap the poly, and wash things out as aggressively as you can, and we will then give them antibiotics after you sew them shut, and we all hope for the best. The failure rate here in most of the published literature is about 30%. So I tell people we got a 2 out of 3 ain't bad. You got a 2 out of 3 chance that we're going to retain this joint. I think it's worth it for all these good medical and orthopedic reasons. But with a success rate of only about 70%, we should be realistic about what this can and can't do. The other reason to do DARE is patient doesn't meet any of those criteria. They do have a sinus tract. It's ancient. They've had symptoms for 2 months. Whatever the case may be, we can still do it if we can't do a 2-stage. And we've all been in this context. This is why orthopedics is fun and interesting. This is why ID is a challenge, right? We do this together because these people were trying to fit a square peg into a round hole. We're not following the rules, but this may still be in the best interest of that patient with their overall wellness and orthopedic plan put together. And I will turn off their antibiotics when they die or I retire. And I don't plan to retire. So the first person to die, then we can stop the antibiotics. They'll take antibiotics for life. That's a huge burden for some people. For others, it's like taking a vitamin. It's highly individualized. We own that process in the ID context. The other treatment pearls are to say that after source control, antibiotics are essential. And, the ideal antibiotic that I want to give these patients should get to the infection, should kill the bug, be non-toxic, no drug interactions, it should be cheap, should be PO. This doesn't exist, right? And so we're always trying to figure out how close we can get to this platonic ideal of what an antibiotic can and should do for our shared patients. Good news is that oral is good. And we've known this for a long time. We've been doing this on the DL, but we now have, thanks to Oviva, good, high quality, randomized information from our center's friends in UK who practice more or less the way we do here. It's very similar. They don't have a lot of shoulders and elbows, but for hips and knees, it's very similar to what we would do here in the States. And what they did was, they got these patients a week of IV antibiotics for a prosthetic joint infection. And then they switched to PO in half and they stuck with IV in the other half. And they followed them, and you can see the outcomes, right? I mean, basically, the oral cases were less likely to fail, basically the same. And those serious adverse events, the big side effects, were about the same or slightly less. Boy, they had a lot less vascular complications because we had fewer PICs that were in place. So these were strong centers. Everyone here in this meeting today is at a leading center. And for those who are trainees, you're going to place in top centers around the country or around the world. So this applies to your context. You have to do it with ID. And I think as you do, it will make these friendships and relationships over time of your career. You're going to see us use a lot of PO. And we're doing it not because we want to do it on the cheap, but because we're trying to do as good a job or better that we can do with IV. It's not always possible. The bugs are not getting easier to treat. You may find times when we just cannot switch to PO because we don't have that as an option. But in general, when we can, that's what you'll see us do. Is there a role for rifampin? You'll see us reach for RIF, and very quickly, as you recall, rifampin gets into biofilms. Patient swallows a pill of rifampin, their urine turns orange, their sweat and their tears turn orange. It's because it's everywhere. So we love it for that reason. It is a good biofilm penetrator. And we know that it can make a difference in patients with prosthetic joint infection due to Staph aureus and also with native spinal infection as well, again, in the Staph aureus context. We do not usually give it outside of staph infections, coag-negative or Staph aureus. That's where it is proven to work. It's oral, it's free. It is just about the dirtiest drug you will find. It is the most interactive cytochrome angry drug. So many side effects of nausea, vomiting, diarrhea, headache, etc. People feel like the treatment is worse than the disease, and a lot of drug interactions. And we never give it by itself. Please never give rifampin by itself. The threshold to resistance is very low, and we'll burn that bridge in a flash. This is a problematic medication. ID, you'll see us start it, and if we have to, we'll stop it, but that should be on us. If there's ever a time when you're looking at rifampin, do I need it or not? Am I going to start it or stop it? Come to us in ID. This is one of our favorite reasons to get an ulcer, worrying about this in our patients. You shouldn't have to worry about that. So I think the opportunity, as I wrap this up here, and then we'll go to Q&A if there's time, call us, or like a voter in Chicago, do it early, do it often, give us a call. Our fellows are really on duty and usually awake, 7 a.m. to 1 p.m. That's the time. And I think ortho is really exemplary in getting us those early consults. We appreciate that. If it's afternoon, we're just the busiest consult service at UW Medicine by far, and we're just swamped. So earlier in the admission and earlier in the day is good. But if it's an emergency, you can call us at any hour. That's okay, exceptionally. And what we really love to do is to hear from someone who was in the case. What did it look like? What did it feel like? What did it smell like? What's your spidey sense? I can't tell you what's wrong, but there's something wrong. This is not what we were expecting to see in this joint, in this case. We really pay attention to that. It may end up being something that's not an infection, but we pay attention to that. That really helps us to understand why you're concerned about the case. We really love working with ortho. You're so responsive, and you're so great to partner with, and you're just so focused on that overall wellness of the patient. I think we have a really similar ethos. So thank you for that, and let's keep that relationship growing. It occurs to me that ortho sometimes feels like this, and so does ID. So maybe we've got that in common. So there's my summary. We've talked about how to prevent prosthetic joints. It's antibiotics, cefazolin, and it's beyond that. We've talked about diagnosis. Tissue is the issue. Swabs are bad, although they're okay as a fallback. And it's bacteria. We're looking for gram stain and bacterial culture. We talked about treatment and how this is really about source control, but just that conversation with us before we sit down with a patient and promise them something that is a fantasy that they're never going to get because of the carpentry and the reality of what you can do technologically. Thank you for making sure we're clear on that. With that, I'm going to pause. And yeah, Albert, glad to do Q&A if you think we have time for that. And it looks like there's some chats. I'm going to see if I can see something in here.
So there was quite a bit of question going back and forth in the chat. Thanks again for that wonderful discussion. And yes, let's feel free to read through the chat and address any of those questions. We can also, anybody can chime in.
What happened if we write?
Go ahead, Dave. Is that
Got it.
Okay. Hey, Paul Manor here. How are you?
It's so good to talk to you, Paul.
Yeah.
Good to see you.
Nice to see you again. What do we do with the joint that looks infected, acts infected? We get in there and there's pus, and then nothing grows.
Yeah, so this is the context. This happens, and that patient may be pre-treated. They may not. Sometimes they just have this rocking neutrophilic response. The pus is doing its job. And I always remind the fellows, like, that's a good sign. So that's one where we would most definitely want to get molecular testing, right, Paul? Because, I'm going to be the one to reap the whirlwind and inherit this person in my practice. So if that's happening, first of all, ID should be involved in the case. Second of all, if not, let us know right away, because we can get in touch with the lab and add that molecular testing. If it's a tissue, actual pus that you've sent down in a syringe or a cup, we'll have a week to figure that out. Cultures are usually held for 5 days. Bacterial cultures will typically grow, in most cases, staph, E. coli, within 2 days. So, Paul, if you've got a post-op patient, it's like post-op day 2, you're like, what are we doing? That's when I would send molecular. It might grow in the next couple of days, but I don't want to wait, and I don't want to let them chuck that precious specimen. Is that helpful?
Yeah, I mean, one of the things that we see is, it's the old story of, a patient referred in has an infection, your patient has a cellulitis, my patient just has a skin reaction. But we see these fairly commonly, where it's an implant that's loose.
Yeah.
And everything about it says this is an infected joint. And so we take the patient in, we do a 2-stage, and then we send samples and nothing grows. And now we're sort of stuck treating a quote unquote culture negative infection, whatever that is.
Yeah, correct. And we hate that. And you're right, it's a sterile site. But if it is indeed an infection, our molecular testing, look, it's not perfect,
Yeah.
but so helpful to get a PCR in that context, because it's probably going to be coag-negative staph, right? This is going to be a staph epi. I've been burned. I've been fooled. It can be Staph aureus too. So or it could be E. coli, who the hell knows? Getting that PCR can be extremely helpful, and we can help with that. I see a hand up from Will. Yeah, Will, please.
Oh, I was just wondering, you had talked about using not using swabs, which I think makes, which I've understood makes a lot of sense based on the evidence. But I was also just a practical question about getting cultures in the OR. So if a patient has you're highly suspicious of an infection, it could be a native knee or a total knee arthroplasty. You've aspirated the joint. Based on cell count, you believe it's infected. You may or may not have a positive gram stain, but you don't have a culture yet, but it's cooking. Would you give preoperative antibiotics? And then let's say a setting where you don't have an aspiration first, but you're doing a surgery and you think that it's infected. So I think usually the reason I'm asking this is because I think dogma has been to hold antibiotics before making the incision when you're going to get intraoperative cultures. But the research, which I think is limited, that I've looked at, would suggest that it does not change your likelihood of getting an accurate culture result. And it makes practical sense to me that it would not affect your result, because if antibiotics were so effective that it would stop your pus pocket from growing bacteria when you give antibiotics immediately before the incision, it seems like we wouldn't have to do surgery.
It's such a great question that I remember very well. This is one of the most hotly debated, Paul, you might agree, at ICM 18. There was a lot of difference of opinion around this. And of course, the rationale for giving the antibiotic is we're doing surgery. We want to reduce the chance of a surgical site infection. So I'm very sensitive to that concept. You're exactly right. But what we've always said is we want to optimize the yield. For God's sakes, don't give antibiotics. And I think that's a different context potentially for a bedside clinic tap of a knee where you're doing arthrocentesis. If we're talking about we're actually going to revise this patient, I think there really is a move towards giving that standard of care, 2 grams of Ansef or 3 if they're a larger patient, because not only are we trying to diagnose what's in there, we're also trying to prevent a new infection from getting in. So I think there's at least equipoise around this. What really moves the needle more towards giving standard, it's not just the flow and making it easy to do what a standard thing in the operating room. It's also the ideas we've been talking about here in the previous question. Our molecular testing is quite good. So we do have options well beyond simple gram staining culture. We can do a PCR test as well. I think my friend Maggie Green might be here, and Maggie actually sees more of these cases than I do. Maggie, if you're here, what's your thought about that concept? High suspicion, stable patient going in for a DARE, for example.
I agree. I think they should get the standard antibiotics peri-op, and then we'll start broader coverage, after their surgery.
I think part of the reason, not to interrupt, but part of the reason I asked that I'm excited about this question is that, there's a relatively high percentage of patients who recur with a different infection. At least that's my understanding in total knee arthroplasty. Of the patients who recur, there's at least a subset who recur with a different or an additional bacteria.
Yes.
Those patients are obviously high risk for infection because they already have an infection. So I think that's my logic on it, which I think lines up with what you're saying. And then in native knees, about 15% of patients who get surgery for a suspected native knee infection actually don't have an infection. So right. You're just doing an IND on a knee without antibiotics of a uninfected knee. So it's just an interesting problem.
It
Correct.
is.
The other thing, Paul, I will say about the molecular testing is that, I heard Dr. Manner, we definitely have plenty of cases or that cultures are negative and the PCR is negative, so it isn't 100% sensitive, and that's a problem. And the other thing is that culture is always better, because then we do get the organism and we get susceptibility data, which we do not get with the PCR identification.
Yeah. Yeah. I mean, I think molecular is a gift that we have. Sometimes it helps. It is not as good by any means. And that's why we were talking about not doing that on a routine basis. We can always add it if cultures fail to grow. Thanks for that reminder, Mickey. And then from Corey, the man who grapples with the Cutibacterium. Here's a text. Thanks so much, Paul. We think of Cutibacterium as an indolent infection, but I've had 2 healthy patients with frank pus and my friend Frank pus and an aggressive presenting infection. Do you think this is more due to aggressive strain of cutie, or could it be a hole in the patient's immune system? And the answer is yes. I mean, it can be either of those things. Roger Bumgarner and others within our department of not clinical micro, but the microbiology research department have had an interest, thanks to Dr. Rick Mattson, who's been trying to push for this for a long time, to understand what is happening on the micro side with Cutibacterium. Are they getting more aggressive? I can tell you, I have seen Cutibacterium infections in the spine as well as shoulder and elsewhere. They can make hella pus, and I think it can be aggressive. I've never known the answer to that question. In my experience, these tend to be a combination of both of those things. Diabetic patient with an abnormal immune system for some other reason. And I'm worried that they may also have had, a very quick onset of infection. So Cutibacterium seems to go down 1 of 2 pathways. It either smolders and lingers, chewing away on your humerus like termites on a mighty oak tree, or it can become very, very florid. And in those florid cases, I think they're patients with rotten immune systems, but it would be so interesting to get some research dollars into that concept and see what's happening on the micro side. Good question. I think we're at time, although I'm happy to stay on. And Albert, I really do appreciate, thanks for having me and Maggie on here. For those who haven't met Maggie Green, she's the person to see up at Northwest with inpatient or follow-up outpatient issues in orthopedics. She sees these cases with you. And if you haven't yet met with Maggie, you're really fortunate to have her up there in your practice.
Yeah, thank you very much, Maggie. I saw her answering all the texts
Great. That's
as
great.
we were going along, which is it's wonderful that you brought your partner with you to help manage the chat room. Paul, thank you again. Wonderful talk. Like I said, always incredible that we have such great partners on the ID side who obviously we are calling upon fairly regularly, unfortunately, but thanks for all your collegiality and your entire department as well. Thank you, everybody.
Total
Have a
pleasure.
good
Thanks
day.
all. Yeah,
Yeah.
you too. Be
Thanks,
well.
Paul.
Thank you, folks. Cheers.